Assalamu alaikum. My name is Hussien Alzayer. I'm an interventional cardiologist from Saudi Arabia, Eastern Province. I'd like to thank you for your kind invitation to give this talk. My talk today will be about OCT-guided PCI. So why do we need to use OCT? So angiography alone provides a luminogram depicting planar projections of a 3D coronary tree. So it's basically a 2D projection rather than a 3D. The angiogram does not image the vessel wall. Intracoronary imaging, whether IVUS or OCT, enables cross-sectional tomographic images of the coronary tree. So OCT, or optical coherence tomography, utilizes near-infrared light directed at the vessel wall through a rotating single optical fiber coupled with an imaging lens within a short monorail imaging sheath. Flushing is required to displace blood during OCT acquisition, since blood strongly scatters light and attenuates the OCT signal. OCT has a shorter wavelength of infrared light compared with ultrasound in IVUS. As a result, OCT has greater axial resolution but lower penetration depth, which limits OCT imaging, particularly in the presence of highly attenuating structures such as red thrombus or lipid. So why do we need to use OCT? So this was published in November 2022, and they concluded that OCT changes the plan of the interventional cardiologist in up to 86 or 87% of cases. Basically, the decision changes when you use OCT, particularly when you do pre-PCI OCT. In terms of image acquisition, so the commercial OCT imaging system consists of an OCT imaging catheter, the drive motor operating control, and an imaging software. The imaging catheter is attached to the purge syringe and is flushed with the same material planned for coronary flushing and is attached to the drive motor operating control. You always need to give intracoronary nitroglycerin before you do your OCT run to eliminate spasm. As you can see on the image in the right-hand side, this is the angiogram of the RCA, and you can see the OCT catheter. It has a proximal marker, it has a lens marker, and a distal tip marker as well. So what are the steps for image acquisition? So the steps can be summarized as the 4 Ps: position, purge, puff, and pullback. So in terms of position, you need to position the catheter after the lesion. Then you purge to make sure that the lumen is clear of blood. You need to puff to make sure that you have good distal clearance and that your guide is well engaged. And then you trigger your pullback. And this can be either automated or can be manual. If you're using an automated injector, the recommended contrast flush rate should be 4 ml per second with a total volume of 14 to 16 ml. If you're imaging the RCA, then it's recommended to use a contrast flush rate of 3 ml per second and a total volume of 12 to 14 ml. And for the automated injector, the pressure limit should be set at 300 psi. You need to do a cineangiography during the pullback to utilize the contrast injection for angiography and for OCT co-registration if the feature is available. So these are the steps. So initially you need to prepare the dock controller, launch the Ultron software if you have it. The previous version was 1.0. Now there's a newer version, which is the Ultron 2.0. You need to prepare the Dragonfly catheter and connect the pieces. after positioning the catheter distal to the lumen, so you just go for the 4 Ps. So position the catheter distal to the lumen, you purge the blood from the catheter, you puff the contrast to confirm the position, and then you trigger your pullback. In some centers, you can do co-registration if the feature is available. Basically, you co-register your OCT with the angiogram, and this will help you determine your landing zones for stenting. So using OCT pre-PCI will help to identify the culprit lesion, will help you assess the lesion morphology, and will help to characterize the stent landing zones. This is a nice algorithm. So this is called the MLD max. And this is the proposed algorithm when you do an OCT run. So MLD for your pre-PCI and max for your post-PCI. So once you do the OCT run, you need to assess your MLD, meaning morphology, length, and diameter. And after that, you determine your strategy. For example, if you need to stent, you need to post-dilate or optimize, and then you do your post-OCT run, and you assess for max, meaning medial dissection, apposition, and expansion. So for morphology, you need to understand the normal histology of the coronary artery. So the vessel wall has, as you all know, and intima and the media, there's the internal elastic lamina, and between the media and the adventitia, you have the external elastic lamina. And this is what it looks like on the OCT. You can see the most inner layer is the intima, and then you can see a dark band, which is the media, and the outer layer is the adventitia. And the outer part of the dark band or the media is called the external elastic lamina, or EEL. And this is very important when it comes to sizing your stent. So in terms of morphology, so what are the most common morphologic plaque appearance that you see on OCT? So there is calcific, lipidic, and fibrous. Calcific on the far left-hand side, you can see that calcium is very well delineated and very well demarcated. You can actually draw it, and you can identify the borders. In the middle, you can see the lipidic plaque. The lipidic plaque is very dark, homogeneous, and is very diffuse. On the right-hand side, you can see fibrous plaque, which is homogeneous, but is very bright. So in terms of assessing pathology on OCT, so the first question is, you need to ask yourself, is the pathology in the lumen or in the vessel wall? And can you identify all 3 layers of the vessel wall? If you can identify clearly all 3 layers of the vessel wall, then you have one of 2 things. So either the vessel is normal, such as in the image on the far left, or if you have very bright appearance, then that's fibrous plaque. If you have an issue in the lumen, then it has to be thrombus. If it's thrombus, you have 2 types of thrombus. There is white thrombus and red thrombus. White thrombus is characterized by low attenuation, meaning that you can see behind it. Red thrombus is characterized by high attenuation. You can basically see nothing behind it. If the pathology is in the wall, so it's one of 2 things. Either you have high attenuation, meaning there is lipid plaque, as you can appreciate, is very dark. You cannot see anything behind it. And either low attenuation, which is calcium, well demarcated, you can identify the borders of the calcium. And this is the hallmark of calcific plaque. So Why identifying morphology is important? So when you identify your morphology, you can determine your strategy. If you have lipidic plaque, you can do direct stenting, meaning that you just deploy your stent and that's it. And then you determine your post-dilatation balloon if needed. If you have fibrotic plaque, usually you need to predilate with some sort of ballooning, either a compliant balloon, sometimes you may need NC balloon or cutting balloon. If you have mild to moderate calcification, then you should start always with a NC balloon or a non-compliant balloon. If it doesn't crack, then you may need to upgrade to a cutting balloon. And if you have severe calcification, as depicted on the picture on the right-hand side, you may need to use IVL or atherectomy, either orbital or rotablation. This score has been developed to help decide on your calcium modification strategy, and it's called the calcium volume index score. And it has three components. You need, and this is basically depicted on the OCT with the newer software. This is all automated. So you have the first component, which is the maximum calcium angle or the arc of calcium. If you have more than 180 arc of calcium, this gives you 2 points. If you have a maximum calcium thickness more than 0.5, you get 1 point. And if the calcium length is more than 5 millimeters, then you get 1 point. And the higher the score means that you need to consider more aggressive modification, calcium modification techniques, such as atherectomy or IVL. And as you can see, this is the Ultron, the OCT with the Ultron software, and it's all automated. So the calcium is indicated in orange, and you can see on the picture you have a total angle or an arc more than 180, so it's 200, and the maximum thickness is depicted in white, so it's around 0.73, so more than 0.5 millimeters. The length, you need to scroll down the longitudinal part of the image to measure the length. But given the total angle and maximum thickness, you already have a score of 3. So in this example, you may need at least IVL or a cutting balloon. And also in this example, on the right-hand side, you can see the image where you don't have any calcium in the middle. There is some calcium at 1 o'clock and at 3 o'clock. And on the image on the right-hand side, we have a lot of calcification from 12 to 3 and from 7 to 11. So the total angle is around 210, and the maximum thickness is more than 1. So in this example, you need to consider NC balloon, cutting, scoring balloon, atherectomy, IVL, etc. While in the first two examples, you can either get away with direct stenting or just pre-dilatation with a regular balloon. OCT also helps you identify vulnerable plaque. You can appreciate on the image on the left-hand side what we call as TICFA, which corresponds or means basically thin cap fibroatheroma. Why is this important? This is important because if you end up landing your stent in these areas, you may risk dissections, etc., and target lesion failure as well in the future. So when you see these lesions, you should think about covering them with stents if you have severe stenosis. In terms of length, so you need to scroll through the OCT cross-section, and the most normal appearing segment within 5 millimeters are selected as proximal and distal reference. And when you select these normal reference frames, you need to basically make sure that you can identify the EEL. So when you identify a normal proximal segment and a distal segment, which is normal, then you can calculate your stent length. And with OCT, the most newer versions, the Alzayer 1.0 and 2.0, will give you the entire thing automatically. So for this example, you can see in the image on the right, the Alzayer software calculated the length, and it suggests a stent length of 23 millimeters. It identified a near normal proximal landing zone, and it measured an EEL of 3.9, and also identified a distal normal or near normal landing zone measuring an EEL of 2.82. So in this example, for example, you will use a stent length of 23, and you will size your stent based on the distal reference. So if you have an EEL of 2.82, you need to round down to the nearest stent size. So for example, you can use a 2.75 by 23 millimeter stent, and then you can do your optimization proximally with a 3.5 or short 3.75 NC balloon. So again, the diameter, the vessel diameter, you need to identify the EEL. And if you have the EEL, you need to round down to the nearest balloon size or the nearest stent size. So if you're using the EEL diameter, you round down to the next quarter size. And if you're using the lumen, if you cannot identify the EEL, you need to round up to the next quarter size. So in terms of co-registration, so basically what it means, it's basically a software for automated real-time point-to-point correspondence between the coronary angiogram and the OCT. If you have this, it will help you identify the proximal and distal landing zone, and it will prevent or reduce the errors in manual co-registration. So it will reduce the likelihood of stenting in plaque and whatnot. So you finished with your PCI OCT run. You put your stent, and then you need to do your post PCI run. So in this example, you need to assess for MAX, so medial dissection, apposition, and expansion. So these are examples of dissections. And on the image in the left-hand side, you can see a dissection which only involves the intimal layer. In the middle, the dissection is more severe, so it extends to the medial layer. And on the image on the far right, this is intramural hematoma. So this is a very severe dissection. So if you have a small dissection, or if the dissection does not involve the media, then you can leave it alone. However, if you realize that you have a significant dissection that extends into the media and is more than 1/4 arc of the vessel, then you need to cover this. And this is an example of an important dissection. As you can see, the dissection reaches the medial layer and is more than 1 arc of the vessel wall. Moving on to apposition. Apposition means that the stent should be in contact with the vessel wall. If the stent is in contact with the vessel wall, that means that the stent is well apposed. If you see that the stent is not in contact in the vessel wall, So this means that the stent is malapposed. And in terms of important malapposition, if the malapposition is more than 3 millimeters in length or more than 0.3 millimeters from the wall, then this should be treated. And basically, we can use a semi-compliant or an NC balloon at low pressures to correct for malapposition. And depending on the threshold determined by the physician on the software, the system will identify malapposition. So as you can see in the image on the right-hand side, there is malapposition. What about expansion? So if the stent expands the lesion to diameters close to or equaling the diameter of the artery, the stent is considered adequately expanded. The current European consensus is that an MSA or a minimal stent area more than or 80% of the mean reference lumen area and or more than 4.5 millimeters square on OCT is considered acceptable. And in this example, you can see that there is some sort of underexpansion, but depending on the threshold determined by the physician, if you choose a threshold less than 90%, the Ultron will show that you have some degree of underexpansion. However, overall, an expansion threshold or an MSA around 80% is considered acceptable. If you have more than 90% expansion, then that is considered to be optimal. So anything less than 80% should be treated with an NC balloon. What about an ACS? So IVUS versus OCT. So IVUS has extensive clinical experience overall. Pre-intervention imaging without pre-dilatation is possible in most cases. So you can just put in the catheter and image without the need to pre-dilate the lesion, and can be used in large vessels, ectasia, and in left main. However, the downside is that the images can be difficult to interpret. You may have poor tissue characterization and poor thrombus detection. In terms of OCT, this is characterized by high resolution, as I mentioned previously. Plaque characterization and thrombus detection is better. The images are more clear and easier to interpret. And with the newer version, everything is automated. The downside of OCT is that it requires additional contrast and may have limited penetration. OCT is not good when you have ostial left main or if you have very large vessels. OCT is better when it comes to determining the etiology of ACS, including better thrombus detection. It better detects the culprit lesion in ambiguous situation. For example, if you have an NSTEMI with multiple lesions in multiple vessels, so OCT will be of use in this scenario. And it is better when characterizing the composition of atherosclerotic plaque and also vulnerable plaque. So what is the etiology of ACS most commonly seen in OCT? So in most cases, the vast majority or more than 2/3 of cases, you will see plaque rupture. In 1/3 of cases, you will have plaque erosion. And in a minority of cases, you will have calcific nodules. So what does plaque rupture look like? So as you can see in the image on the right, this is plaque rupture. So you have severe disruption in the vessel wall and discontinuity in the fibrous cap. with associated red thrombus as well. What about, so this is also plaque rupture. So you can see red thrombus, meaning that you cannot see anything behind this lesion. What about plaque erosion? So plaque erosion, this happens or occurs in 20 to 30% of patients presenting in ACS. So in plaque erosion, there's no disruption in the vessel architecture. So the vessel appears to be in decent shape. However, you can see white thrombus, or you can see some irregularity in the lumen surface. White thrombus, you can see, is low attenuation, meaning that you can see behind the thrombus. And in these scenarios, you can decide not to stent or defer stenting, depending if you have, for example, very large minimal lumen area, then you may choose to defer stenting. What about calcific nodules? So this is the least common cause of ACS, and it is characterized by single or multiple regions of calcium protruding into the intracoronary lumen and can form sharp angles. This presents, in about 5% of cases of ACS. And in these cases, you need to think about aggressive calcium modification. So we can stop here if anyone has any questions, and we can present some cases. Okay, so this is an example of a clinical case. So this is a 40-year-old gentleman who presented with an NSTEMI. Risk factors include dyslipidemia and prediabetes. His ECG showed sinus rhythm with dynamic ST depression in the precordial leads. He had an echocardiogram which showed an ejection fraction of 30 to 35%. His blood work showed high troponin. LDL was 4, hemoglobin A1C was 6.1. So this was the coronary angiogram. As you can see, the RCA had significant disease in the distal segment at the crux before the bifurcation. Imaging of the left system showed an unobstructed left main. There's mild plaque in the proximal LAD, followed by severe critical lesion in the mid-LAD or proximal LAD just before the bifurcation with the diagonal. So this was basically single or double vessel disease, low syntax score. So we decided to proceed with PCI, and we decided to proceed with intracoronary imaging. So an OCT was done, and this was the OCT run. This was the pullback, as you can see. So the pullback from proximal to distal on the Ultron. So as you can see in the proximal vessel, there's mild plaque, relatively normal, healthy tissue, and in the critical stenosis in the mid-segment. And there was basically a tissue after the stenosis in the mid-segment. Left, you can see significant calcification. The calcium arc, however, was less than 180, and the thickness was less than 0.5. And this appearance, as you can see, the last presentation, this was in keeping, this image or this shape was in keeping with a calcific nodule. So as we said, with calcific nodules, you need to consider more aggressive forms of modification. However, in this case, so just a brief overview over calcified nodules. They are small, rounded, calcified fragments. They're separated by fibrin within luminal protrusion, and can be characterized by fibrous cap disruption. They can have overlying thrombi in cases of ACS. And as I mentioned before, they're the least frequently found in cases of acute coronary syndrome, and can also be found in non-culprit coronary lesions. Um, Calcific nodules there are two types. So there are eruptive and non-eruptive calcified nodules. The eruptive calcified nodules are the ones which cause ACS, whereas uh, non-eruptive calcified nodules are usually stable. In both scenarios, however, you need to consider aggressive modes of calcium modification. So we decided to proceed with PCI. So we wired both vessels, diagonal and LAD, and we pre-dilated the diagonal just to keep it open. And then we decided to use calcium modification and started with a cutting balloon or a Wolverine cutting balloon. And there was decent expansion with the cutting balloon. So we decided to obtain a post-OCT run, a post cutting balloon run. So this basically showed the effect of the cutting balloon on the lesion. And as you can see, there is iatrogenic dissections, which means that the lesion has yielded and responded very well to the cutting balloon. So we decided to go ahead and stent. So we delivered a stent covering the proximal and mid LAD, and this was all determined by OCT. And then we did a pot for our post-dilatation, and you can appreciate that the stent was well expanded uh, and the lesion has yielded. And this was the final OCT run from proximal to distal. You can see that there was excellent expansion, well apposition, no proximal or distal dissections. And this was the final angiogram. So usually, when you have uh, uh, calcified nodules, you need to consider usually aggressive modalities for calcium modification. But in this example, cutting balloon was a good alternative, and the lesion has responded very well to this technique. So cutting balloon can also be considered in cases of calcified nodules as well. Okay, I can see a question. What is your take of IVL in calcified nodules? So I believe IVL can be a good example. I think IVL can be used in calcified nodules, provided that you have a good lumen. If you can deliver the IVL balloon to the lesion, then you can definitely maybe worth a try. However, in most cases, you may have critical stenosis, so maybe difficult to deliver the IVL balloon because it's also very bulky. In this scenario, we'll just move on with this case. So this is a case of a 47-year-old gentleman presenting with chest pain for 3 days on and off. He did not have any previous history of coronary artery disease. His cardiac risk factors included heavy smoking, hypertension, and diabetes. His medication list was unavailable. So this was his ECG showing non-specific ST changes, and the patient was advanced for coronary angiography. The right coronary artery had no significant disease, just very mild irregularities. The left system was more or less co-dominant. The left main was unobstructed. You can see the LAD with a critical long lesion from prox to mid-segment. And the ramus and the left circumflex had no significant disease. So in this case, I decided to do OCT, and I was lucky to have a decent image. I did not have to pre-dilate, but usually when you have a critical lesion, you sometimes need to pre-dilate in order to get good images and in order to be able to deliver your catheter beyond the lesion. So this is the old version of the OCT system. So as opposed to the um, Ultron software, this is the Optis Mobile. So in this scenario, you can have, it will show you the lesion from distal to proximal. And as you can see, we'll just repeat this. Distally, you can see relatively healthy normal vessel wall. And then you can see a significant stenosis with high attenuation, very high lipidic core with overlying thrombus. You can see the lipid pool was very long and huge. And then you can see the proximal segment of the LAD is healthy. So we identified, we measured the proximal and distal segments and identified that the distal lumen was like a 4O vessel. And we decided on the length. So it was the lesion length was measured at 34 millimeters, as you can appreciate in the longitudinal run. So in this scenario, because we had mainly a high lipid pool with some thrombus, I decided to proceed with direct stenting. So I used a Resolute Onyx 4O by 38 millimeter stent. And I just did direct stenting and then used a 4O NC to post-dilate the distal stent and 4.5 NC to pot the proximal segment of the stent. Here I did the pot puff sign. So I basically inflate the NC balloon and deliver a small puff. And this can also give me an idea whether the stent size is good for the vessel wall, because as you can see, the stent completely occludes the vessel. So this gives me confidence that I'll have a final good result. And this was the final OCT run. As you can see, there was excellent expansion distally, more than 98%. There was some artifact because of poor, vessel, poor clearance of blood. So the system has given me an expansion of 67%, which is not acceptable. But you need always to interpret the image yourself, not always depend on the system. And when looking at the images, the stent was well opposed, well expanded. So I decided to leave it at that. So this was a nice example of direct stenting. This is another case of a 42 male who presented to another center back in September 2021 with chest pain and positive troponin. He had cardiac risk factors, he had cardiac risk factors including previous history of smoking, and positive family history of premature coronary artery disease. His 2D echo showed mild LV dysfunction with no significant valve disease. And he was referred for urgent inpatient left heart catheterization. So this was his ECG, non-specific changes. And this was his diagnostic angiogram. So he had a non-dominant right and a dominant left system. The left main was fine. The left circumflex had only mild irregularities. And he had a long segment of disease from the proximal to mid-LAD and diagonal vessels. So we decided to proceed with PCI. So in this example, I wired both LAD and diagonal. I pre-dilated the LAD and pre-dilated the diagonal, and then went on to do OCT of the LAD. To determine my strategy. Again, this shows the pullback on the right system gives you the LAD from distal to proximal. As you can see, there's some poor clearance of blood, but the vessel looks healthy. And you can see some fibrous plaque with iatrogenic dissections because of the ballooning with significant stenosis. You can see the iatrogenic dissections, and mainly there was fibrous plaque with not a lot of calcification. So in this example, we did not need aggressive, techniques for calcium modification because the vessel appeared to be compliant. So I decided to treat the mid-diagonal first. So I did direct stenting of the mid-diagonal. And then I decided to place a stent in the LAD. So I knew from the OCT that I'd need two stents. So I delivered two overlapping stents to the LAD, post-dilated, and then did a post-OCT run. As you can see, we had very excellent expansion across the LAD with no dissections in the distal and proximal segments. And this was the final angiographic result. The ostium of the diagonal appeared to be pinched, but I elected to leave it alone as the patient was clinically stable with no ECG changes. So just the patient was doing okay until he presented after 2 years with chest pain lasting for about 2 days. He was compliant to medical therapy according to him. His troponin was elevated, and again, he was referred as a case of NSTEMI for inpatient left heart catheterization. So this is the same patient. He came after 2 years, okay? So this was the left system, and you can see that the left system was fine, and the angiogram was okay. We did OCT, which did not show significant stenosis. The stent was widely patent in this example. So, someone mentioned something about Minoka in the question. So always OCT is, can be useful when you have a Minoka, when you don't see obstructive lesions. Sometimes OCT is helpful, especially it may help you find other causes such as plaque erosion. So in this example, there was some new intimal hyperplasia, but the stent was widely patent, looked decent. So the patient was just treated medically. يعني this is a final case if you guys are still interested. يعني we can just go through it quickly. But this is a 50-year-old gentleman who came in with chest pain, anterior STEMI. He had all the typical risk factors. He went for primary PCI. RCA was fine. He had disease in the LAD, which appeared like a thrombus. So we proceeded with thrombectomy, and then we did primary PCI. So this was the index procedure. He presented a few years later with chest pain for 1 month. He had positive troponin. Ejection fraction was mildly reduced. And he was referred for another angiogram. So the RCA was fine. And the angiogram of the left system showed severe ISR, so showed complete occlusion of the LAD stent. So in this case, we pre-dilated with a balloon, and we pre-dilated basically to reestablish flow. And as Dr. Fawaz mentioned, OCT can be very helpful in these scenarios to identify the cause for stent failure. So we did the OCT run, and as you can see from the pullback, there was, a lot of neointimal hyperplasia. And when you have neointimal hyperplasia, you can also have plaque rupture within the stent. So this is very helpful because in these patients, when they are non-compliant to medical therapy, this is what happens. So in this example, we went in aggressively with a large NC balloon and ended up putting a drug-coated balloon. So we post-dilated based on the stent diameter, and we ended up putting a 3.5 by 25 drug-coated balloon. And the final result was very good. We'll just so the stent was very well expanded, as you can appreciate. No significant dissections either distally or proximally, and did not have to put any new stents. I'm going to conclude my presentation, and if anyone has any further questions, Allah ya'tikum al-afiyah. Shukran.